the internal ear, otitis media and externa, myringotomy and intraocular muscle. So first we'll start with the competency describing the features of internal ear. So in the picture you can see it is the base of skull. The internal ear lies within the thick protective walls of Peter's part of temporal bone. Internal ear consists of two main divisions, that is bony labyrinth and membranous labyrinth. So in the circle part you can see the Peter's part of temporal bone. So the arrow showing the Peter's part of temporal bone in the base of skull. Coming to bony labyrinth. Bony labyrinth has three parts. These parts are, on the left it is semicircular canals. On the right it is cochlea. In the center, in the narrow part, that is called the vestibule. So bony labyrinth has got three parts: semicircular canals, vestibule and cochlea. Membranous labyrinth. It consists of continuous series of membrane walled sacs and ducts. So they are sacs and ducts, and that fit loosely within the bony labyrinth. They are made up of thin layer of connective tissue, and they are lined by, on the inner side, by the simple squamous epithelium. This epithelium is thickened at certain parts and contain or help as receptors for equilibrium and hearing. The main parts of the membranous labyrinth are, as in the bony labyrinth, semicircular ducts. On inside of each semicircular canal. Semicircular ducts contain the sensory receptors for turning movements of the head. Then second, in the vestibule we have utricle and sacule, that you can see in the picture. The upper part is utricle, the lower part is sacule. These contain sensory receptors that monitor position and linear acceleration of the head. Then we have the third, that is the cochlear duct. It is located within the cochlea, and the cochlear duct contains sensory receptors for hearing. So cochlea is related to hearing. Then we go to study another competency, that is anatomical basis of otitis, externa and media. Externa is external ear, media is middle ear. Otitis externa. First we'll see the external acoustic meatus. It is 2.5 centimeters long and it is S-shaped. It has an isthmus at the junction of cartilage and bony parts. Its skin has hair follicles, sebaceous glands and ceruminous glands. The ceruminous glands secrete cerumen, which is protective in nature. Then we come to classify otitis externa. So it is classified as acute and chronic. In acute type, we have diffuse type, that is swimmer's ear, and a localized type, that is called furunculosis. In chronic otitis externa, we have automycosis or non-infective type, necrotizing or malignant otitis externa, and herpes zoster oticus, also known as Ramsay-Hunt disease. So first we'll start with acute otitis. In acute otitis, we have swimmer's ear. It is the infection of external acoustic meatus. It is rarely complicated, but there can be acute morbidity. Male and female are equally affected. And the peak when it affects is between 7 to 12 years. It is due to trapped moisture in swimmers and in humid climates. Then we go to, again, swimmers. It can be due to trauma of external acoustic canal, or can be foreign bodies such as cotton buds, paper clips, pencils, or due to wrong cleaning by a quack. Then we go to localized furunculosis. It is in the lateral 1/3 of external acoustic meatus, and there can be a pustule developing into furuncle. Then we go to chronic otitis externa. In this we have automycosis, that is fungal disease, and Aspergillus and Candida is the most common pathogen in automycosis. Non-infective type, chronic eczematic external otitis, it can be, or it can be seborrheic dermatitis, can have secondary bacterial infection, and it is seen commonly in women and those who have hair over their ears. Then necrotizing or malignant otitis externa. This is seen in immunocompromised people like diabetes mellitus or elderly persons. Pseudomonas infection is common. It begins as acute otitis externa, then progresses to skull base as osteomyelitis, and there can be cranial nerve neuropathies accompanying this. Then Ramsay-Hunt syndrome. In herpes zoster of pinna, that is shingles, there is otolgia and facial paralysis. The varicella zoster virus is dormant in the nerve or ganglion of facial nerve. There is burning pain, headache, malaise, and fever for few days. Vesicles appear in between 3 to 7 days after the onset of pain, and they usually erupt on antihelix, as shown in the ring. You can see the antihelix, the conchal bowel, and posterolateral external auditory canal. Then we go to otitis media. It is the infection of middle ear fluid. It is most commonly seen between the ages of 6 to 24 months. It can be viral, bacterial, or both. Without proper treatment, middle ear infection can extend to adjacent anatomical locations and result in complications which include tympanic membrane perforation, mastoiditis, labyrinthitis, petrositis, meningitis, brain abscess, hearing loss, and cavernous sinus thrombosis. Anatomical basis. They include genetic predisposition, mucin abnormalities of gene expression, anatomical abnormalities of palate and tensor veli palatini, ciliary dysfunction of auditory tube, and even cochlear implants. It is seen commonly in the children. It is a global problem, common in boys than girls. Peak incidence of otitis media occurs between 6 to 12 months of life and declines after age 5. Approximately 80% of all children will experience a case of otitis media during their lifetime. Then mechanism of development. Otitis media starts as an inflammatory process following a viral upper respiratory tract infection. Due to narrow anatomical space of middle ear, edema caused by inflammatory process obstructs the narrowest part of eustachian tube or auditory tube, leading to decrease in the ventilation of the middle ear. Then it progresses to acute suppurative otitis media. So this leads to creation of or increase in the negative pressure in the middle ear. And there is buildup of mucosal secretions allowing for colonization of bacterial and viral organisms in the middle ear, leading to suppuration, that is pus formation, and this can be demonstrated as clinical signs of acute otitis media, such as there will be bulging of the tympanic membrane or redness or erythematous tympanic membrane, and also we can visualize the middle ear fluid. Then we go to explain anatomical basis of myringotomy. So this is a procedure. Myringotomy is a procedure. An ear speculum is introduced into the ear to see the eardrum. Then a radial incision is made in the anterior quadrant as shown, around the region of light reflex. And this is done with myringotomy knife. So in the picture you can see it is done in the anterior-inferior quadrant. That is the area of light reflex. Then incision. In the postero-superior quadrant is avoided, as that could injure ocular chain or the chorda tympani nerve. And the incision is large enough so that it accommodates a ventilation tube. So in the picture you can see in the circle drawn, we avoid postero-superior quadrant because of ocular chain and chorda tympani. So that is the anatomical basis for giving myringotomy in the anterior-inferior quadrant. Then we go on to describe the position, nerve supply and action of intraocular muscles. According to Gray's anatomy, the orbitalis muscle of Muller is a thin layer of smooth muscle bridging the inferior orbital fissure. So for convenience sake, it is termed as orbital muscle. Functions. Orbital muscle has been considered to cause exophthalmos, as occurs in thyrotoxicosis or hyperthyroidism. It also regulates venous drainage of the orbit, and it is under autonomic nerve control. Embryology. Orbital muscle covers a large area of human fetal orbits. Fetuses have large inferior orbital fissure. According to a study, almost 50% of fetal orbital floor is made up of orbital muscle. So that is the nerve supply, embryology of the intraocular muscles. Thank you.